topic of discussion is small gut and the beginning of the large gut. There are two structures at the beginning of the large gut. They are cecum and the appendix. Now, what is the small gut or small intestine? Small intestine starts from the duodenum. That means at the end of the pylorus, we find the C-shaped duodenum first. Already we have some idea about the duodenum. It is a C-shaped area. And it accommodates the head of the pancreas, and as a whole we have found the composite viscera of duodenum, pancreas and the spleen. Now we have seen that in the duodenum, inside the duodenum we got some circular folds. Those circular folds are either complete or incomplete. These folds are called the folds of Karkring. And these folds are meant to increase the surface area for absorption. Now, what is the function of the small intestine? It is basically digestion, absorption and secretion. Completion of the digestion. After completion of the digestion, there is the absorption of the nutrients, water, and there is secretion. So, to increase the surface area for absorption, so there are some circular folds. Now, we know there are 4 parts, part 1, part 2, part 3 and part 4 of the duodenum. And there is a junction which is called duodenojejunal flexure, from where the jejunum starts. Now, jejunum and ileum as a whole it is around 20 feet or 6 meters. The length is the length of the jejunum and the ileum. There is the viscera. I will show you. The total length is 20 feet or 6 meters. The proximal 2 feet is the jejunum. That means the proximal 8 feet it belongs to jejunum, and distal 3/5, that means next 12 feet It belongs to ileum. Now, the jejunum and ileum, there are some similarities and there are some dissimilarities or differences. In the ileum, in the jejunum or in the ileum, we can find the circular folds. Inside the lumen, we will find the circular folds or semicircular folds. But in jejunal end, the folds are closely placed. The folds are very much closely placed. Now, here we can see what I try to impress on your mind. Inside the lumen, it is a cut section of the lumen, and inside the lumen we can find there are so many folds. This is the cut section of the jejunal end, and this is the cut section of the ileal end. And in the jejunal end, we can find they are closely placed, whereas here we can find they are placed at a distance. In jejunal end, whether it is jejunal end or the ileal end, we will find the villus, plural is villi. In jejunal end, the villi are long. There are the long and stout. Whereas in the ileal end, the villi are shorter or club shaped and thin. Because of this fact, due to closeness of the circular folds in the jejunal end, what we will find? We will have, when we will fill the jejunal end, it will appear as double tube, as if there are two tubes. Whereas in the ileal end, if we feel it from the outside, we will feel that there is a single tube filling and double tube filling at the jejunal end. In the jejunal end, the arteries are coming from the superior mesenteric artery of the midgut. Jejunal and ileal arteries, we already have some idea from the convex end of the superior mesenteric artery. Jejunal and ileal branches are coming out. The jejunal arteries are wider, whereas on the ileal end, the arteries are narrower. So, the jejunal arteries, so on the jejunal end, the gut will appear very much reddish due to presence of wider artery and blood, and on the jejunal end and the ileal end it will appear paler. You can find there are arterial arcades. Here we can find this is the artery, parent artery, from where we can find their arterial arcades. And here we can find the arterial arcades. In the jejunal end, in the first part of the, if we divide the small gut into 4 parts from jejunum to ileum, in the first part we will get only one arterial arcade. On the second part we will get 2 arterial arcade like this. In the third part we will get 3 arterial arcades, and on the fourth part, okay, we can find 1, 2, 3 and more, that 4 arterial arcades. And from the arterial arcades we can find the straight arteries are coming and they are supplying the gut. These arteries are called the straight blood vessels. Straight means rectus. That means vasa recti or rectus. Single is rectus, plural is recti. So here we can we can find the vasa recti. Similarly, here also we can get the vasa recti. This is vasa recti, this is also a vasa recti. Can we find any difference? In jejunal end, the vasa recti are long because there are only 1 or 2 arcades. Whereas in the ileal end, we are getting 3 to 4 arcades, arterial arcades, before formation of the vasa recti. These are called the arterial arcades. So the vasa recti are shorter in the ileal end. If we see the inside of the lumen of the jejunum and ileum, what we can find? The whole gastrointestinal tract. In the gastrointestinal tract, we can find the aggregation of lymphoid tissue. They are called, we know, MALT, malt, GALT, GALT, माने gut associated lymphoid tissues. Like tonsils, there are tonsils, lymphoid follicles. Similarly, in the gut, That means in the small intestine, we can find there are some lymphoid follicles. Within the lymphoid follicles, what we get? Different types of lymphocytes. Aggregation. As per our knowledge of histology, we know there is accumulation of lymphocytes, aggregation, and we can get the lymphoid follicles. So in the jejunal end, we can find, we can see these are the lymphoid follicles. Okay. In jejunal end, we will get the similar lymphoid follicles in the ileal ends also. In the jejunal end, we will get one or two solitary lymphoid follicles. Single. But in the jejunal end, there is aggregation of solitary lymphoid follicles, and we can get this structure. Okay. So these are the solitary follicles, and when they get aggregated, they form this Peyer's patch. In the previous slide, we can find, here we can find one within the circular fold in the jejunal end, what we can expect one or two solitary lymphoid follicles. But here, previous. Here we can find these solitary lymphoid follicles gets aggregated in the ileal end, and it forms the Peyer's patch. And Peyer's patches are present over the anti-mesenteric border. Actually, the whole small intestine, it is hanging from the posterior abdominal wall with the help of a fan-shaped fold of peritoneum, which is called the mesentery. The mesentery actually covers the gut. So there is attachment of the mesentery on one side, and another side is free. So anti-mesenteric means just opposite to the attachment of the mesentery. If we cut the lumen, we can find these Peyer's patches. And these Peyer's patches has got clinical importance. In typhoid fever, these Peyer's patches are affected, and there is a chance of perforation, gut perforation. So, what we can find? There are some similarities and there are some differences between the jejunal end and the ileal end. As per the vascularity, more vascular part is the jejunal end, less vascular part or paler part is the ileal end. Now there is one term which is called peritoneal window. What is meant by the peritoneal window? When we hold the viscera of the small intestine, we can find there is attachment of the mesentery, and we can find the blood vessels also, like these blood vessels. And in between the blood vessels, this area which is been covered by the peritoneum, this is the peritoneum. You can see the peritoneum. And here also we can discover the peritoneum. This outer outline is the peritoneum. So in between the arteries, this area is called the peritoneal window. That means when we hold it against the light, we can see these blood vessels, and we can see this a bit transparent area in the jejunal end. But on the ileal end, these areas are covered. Actually, there is an accumulation of the fat, dense fat in between the arteries. So there is peritoneal window, but we cannot see. Very hazy, because the disposition of the fat starts from the jejunum and it increases as we go distally. So peritoneal window we can find in the jejunal end, and in the ileal end we will not see the peritoneal window clearly. So what is the function of small intestine? It helps in digestion. Here we will find the digestion, absorption and the secretion. So in the terminal part of the ileum, we can find almost all the nutrients are being absorbed. Okay. And from there onwards, the secretion starts, because the undigested material has to come out. So there is a lubrication. This needs a lubrication. So from here onwards, we can find which increases in the large gut, that is the secretion. And the lining epithelium, what is the lining epithelium? We can find the columnar cells. We can find the goblet cells in between. Goblet cells helps in secretion. Columnar cells, they helps in absorption. They have got microvilli. Over the cell membrane we can find there are some microvilli, which the finger-like projections, villi and microvilli. So they help in absorption. So absorption, secretion and digestion, because digestion means there are from this part onwards we can find the pancreatic enzymes, biles are coming and they are getting mixed with the food material, and ultimately the enzymes actually break enzymes actually break the food material into its several components. That means glucose, amino acid, fatty acid, glycerol, what so many material you will learn in physiology and also in biochemistry. So this is the, what is the blood supply? From the superior mesenteric artery. What is the nerve supply? There is definitely a viscera. That means autonomic nervous system will supply. There is, we just ingest our food, we swallow, deglutition, and after that it is beyond our control, beyond our notice. The autonomic nervous system is coming in action. That means sympathetic and parasympathetic. Sympathetic coming from T6 to T9 segments, or okay, through the splanchnic nerves, thoracic splanchnic nerves is coming, and ultimately through the celiac plexus, through the superior mesenteric plexus, through the inferior mesenteric plexus, they supply the whole gut. And there is also a parasympathetic supply from the vagus nerve. Okay. Lymphatic drainage, they ultimately drain into the pre and para-aortic group of lymph nodes. Okay. And we know the cisterna chyli, from where ultimately it drains into the thoracic duct, and the thoracic duct ultimately drains into, we already have some idea where it drains. Sympathetic, parasympathetic, and this is a lymphatic supply. What is the clinical anatomy? Surgical anatomy, there is one, that is the intestinal obstruction. It may be mechanical or any parasite may, that means most common, that is Ascariasis. Ascariasis lumbricoides. There is one worm. At this level I will term it as a worm because you don't have any idea about the microbiology and parasitology. Okay. So actually these worms gets the lumen gets involved with this worm, and ultimately what happens? There is an obstruction. Intestinal obstruction is very important. One has to diagnose very early, otherwise there will be a grave complication. Then any injury, any stab injury, because the central part of the abdominal cavity is being occupied by this small intestine, and the peripheral part is occupied by the large gut. Within the parameter of the large gut, we will get the small gut. So there might be any stab injury, any penetrating injury, whatever might be. Okay, generally small injuries may heal spontaneously, but the large injuries which can affect the mesenteric vessels needs immediate exploration, and like that. Now there is another clinical entity which is called Meckel's diverticulum. It is an embryological diverticulum present. It has connection with the anterior abdominal wall. You can see. It is present in 2% of cases. Actually, during its formation, we can find there is a midgut which has got a connection with the abdominal wall, and this connection actually disappears. The whole tract disappears. But sometimes this part, the proximal part, remains patent. Actually, the whole part, actually from the anterior abdominal wall, from the umbilicus to the midgut, it disappears. But this part actually remains patent. And it is about, it obeys a rule of 2. It is present only 2% of cases. And you can find it is 2 inches in length and 2 feet away from the ileocecal junction. And in 2% cases, it might be malignant. It remains without our notice. We can find, we do not find normally whether myself or anybody of you are suffering from Meckel's diverticulum or not. We do not know. But as we know, there is peptic ulceration in the stomach, and in Meckel's diverticulum there is, we can find those cells which can cause ulceration. We know there is an ulceration in the stomach. Why? There are oxyntic cells, peptic cells. Here we can find these peptic cells. So there is chance of ulceration and perforation also. So if there is a gut perforation, it is a surgical emergency. One has to find out immediately, because otherwise the secretion will come out in the peritoneal cavity. Ultimately there will be peritonitis. Peritoneum will be affected and peritonitis. And ultimately, if it is not detected in proper time, the patient will die. So, Meckel's diverticulum in 2% of cases present 2 inches, actually the length is 2 inches and it is 2 feet away from the ileocecal junction. It is an embryological remnant. It is the remnant of the vital intestinal duct which connects the anterior abdominal wall and the developing midgut. Okay. चलो आप तो किसी नहीं but now about the cecum. Before that, I must mention about the cardinal features of the large gut. In the large gut is present on the peripheral, on the parietes of the abdominal cavity. Centrally we will get the small gut and peripherally we will get the large gut. That means the beginning is the cecum. from where we can find another diverticulum which is called the appendix, then ascending colon, transverse, descending colon, sigmoid colon, then rectum and anal canal. Now there are three cardinal features in the large gut. That is, the first one is the presence of Tinea coli. There are aggregation of the longitudinal muscles, which causes a strap-like appearance over the gut, which is called the tinea. The next is circulation. The whole length of the large gut is only 1.5 meters. Okay. And tinea coli, the length of the tinea coli are shorter than the length of the whole gut. So there is circulation. We can find this, there are some circulations. This is the tinea coli. Tinea coli is, the length of the tinea coli is less than the length of the gut, the large gut. So there is formation of some sacs, which are called the circulations. And already we have seen there is the accumulation of the fats in the small intestine. And here we also can find this accumulation of the fat from the peritoneum, and it spreads over the gut, and we can find grape-like some structures which are hanging from the gut, from the large gut, which contains some fat. These small sacs or bags are called the appendices epiploicy. So these three cardinal features are present in the large gut. Now, about the cecum. Cecum is chobita barko. We can find this is the part which is called the cecum. And from here, from the cecum, another diverticula is coming out, which is worm-like, and it is called vermiform appendix. Vermi means worm-like. So we will restrict ourselves only to this cecum and the appendix. Now what is the situation of the cecum? Cecum is situated over the right iliac fossa. There is a junction between the terminal ileum and the cecum, which is called ileocecal junction. And this terminal ileum and the cecum, what is the situation? That is, what is the situation of the ileocecal junction? There are two lines. This is the tubercle we have found in the ileum, and along with, if we draw a line which is called the transtubercular plane, and if we draw another line from the midpoint of the clavicle, that is mid-clavicular line. So mid-clavicular line and transtubercular line, they will intersect in our abdomen. This is mid-clavicular line, and this is transtubercular line. So the meeting point is the position of the ileocecal junction, and just below that area up to the iliac fossa, up to the inguinal ligament, that area is for the cecum. Now cecum, so here we can find this is the cecum. Okay, position of the cecum. পুরোপুরি লেখা নেই। So what is the, we know this is the position of the cecum in the right iliac fossa. What is the relation of the different structures? Anteriorly we will get the anterior abdominal wall, parietal peritoneum, then we can reach the cecum. And what is the posterior relation to the cecum? If we go posterior to the cecum, we can find there are one muscle, very important muscle, that is iliopsoas. That means the psoas major and iliacus muscle. And also one nerve is coming out, that is the lateral femoral cutaneous nerve, which forms the posterior relation of the cecum. Anteriorly, you can imagine the anterior abdominal wall, and in between anterior abdominal wall and the cecum, in an empty, when the ileum is empty, ileum will come, and cecum is empty, ileum will come, coils of ileum will come, and it will intervene in between the anterior abdominal wall and the cecum. So if we cut the ileum, cecum, we can notice one opening. There are two openings. One is opening in between, there is the terminal ileum and the cecum. So in between ileum and the cecum there is one opening, that is called ileocecal opening, which is guarded by one valve. Okay, so that the material from the cecum cannot go back to the terminal ileum. So that opening in between the terminal ileum and the cecum, there is an opening which is being guarded by a valve which is called ileocecal valve. And this valve is present when we can find, if we cut the cecum, if we see the interior, we can find there is a valve. This valve is nothing but duplication of the mucous membrane. And this valve prevents the entry of the material from the cecum to the terminal ileum, or vice versa. Okay, from the terminal, from the cecum or from the ascending colon, it cannot come towards the ileum, because in the ascending colon from the cecum onwards we will get formation of fecal matter. So fecal matter should not go into the terminal ileum. Okay, and this valve is called the valve of Talpius. And this is that valve which is called the connection between the ileum and the cecum, which is this is the ileocecal valve, which has got two lips, upper lip and lower lip. Upper lip is straight, lower lip is concave. And this valve is called valve of Talpius. And another opening we can find about 2 centimeters below this ileocecal valve. This opening is opening of the appendix. The appendix open, the appendicular cavity opens here. This is the position of opening of the appendix, which is also been guarded by one valve. We can find there is another valve here. That valve is called valve of Jarlach. One is valve of Talpius and valve of Jarlach. Now about the different types of cecum. Cecum actually develops from the midgut. There is a U-shaped midgut during its development, which has got proximal loop and distal loop. From the distal loop, we can find there is a formation of cecal diverticula, and this type where only we can find this, there is no pouches, development of pouch. It's a conical, and from the apex of the cone, this appendix comes out. This is called the fetal type, which is present in adults also in 2 to 3%. The next one is the infantile type, where we can find the development of pouches, and from the apex we can getting the appendix. So there are 2 pouches, but they are not developed much, and from the center we can find the appendicular diverticulum and appendix. Now this is the normal one, where we can find right pouch and small left cecal pouch. And ultimately, when this right pouch is developed, this appendix is shifted more medially. This is the normal position of the appendix. So this is called adult type, which is present in 90% of cases. And again 2 to 3% of cases, the right cecal pouch is more developed, which is called exaggerated type, which is again present only 2 to 3% of cases. So different types of cecum. Now about the arterial supply. What is the arterial supply of the cecum? It is by the anterior and posterior cecal artery, which is coming from the ileocolic branch of the superior mesenteric artery. Superior mesenteric artery has got middle colic, right colic, ileocolic. Mone porche? That ileocolic branch, from the ileocolic branch, anterior and posterior cecal arteries are coming. What is the peritoneal relation? It is covered by the peritoneum from all sides. In few percent, a fold of peritoneum is present on a part of the posterior wall of the cecum is free from the peritoneum. So this is the arterial supply. This is the anterior and the posterior cecal arteries. And also we can find another artery There is then appendicular branch from the ileocolic artery, which supplies the appendix. Now appendix, what is appendix? Appendix is a rudimentary organ. What is the length? It may vary from 2 to 20 centimeters. Average is 9 centimeters. It looks like a worm. So it is called vermiform appendix. There are many positions of the appendix. You can see there are many positions of the appendix. We must know the different position of the appendix, because when we will perform the surgery, we must keep an idea in our mind. We can find the appendix in these regions. Either we can find in the 12 o'clock position, okay, the behind the cecum, which is called the retrocolic position, which is the most common position, retrocolic. It may be directed towards the spleen. Okay, these two positions are directed towards the spleen. That means it is directed towards the spleen, which is called the 2 o'clock position or the splenic type. Splenic type towards the spleen. It is directed towards the spleen or 2 o'clock position. And the 2 o'clock position might be in front of the cecum, in front of the ileum, or behind the ileum. Here we can find it might be behind the ileum and it might be in front of the terminal ileum. And this position, that is which is pre-ileal type, is very dangerous. This pre-ileal type of appendix is dangerous because if there is appendicitis, it can affect the peritoneum readily. It can affect the peritoneum readily. And there might be peritonitis. The next position is horizontal, or towards the 3 o'clock position, or towards the sacral promontory. Another position which is directed towards the pelvis, which is called pelvic type or 4 o'clock position. This pelvic type of appendix, if there is an appendicitis, which may mimic the salpingitis or oophoritis. Oophoritis is the inflammation of the ovary or the fallopian tube or uterine tube. It may mimic as if the patient is having oophoritis, that means inflammation of the ovary or inflammation of the uterine tube. So, this, and also it may mimic with the ectopic gestation. In ectopic gestation, we will also, what is ectopic gestation? When it is outside the development of the embryo outside the uterine cavity. So, when it is ruptured ectopic, there is an pain which may mimic with the inflamed appendix. So pelvic type is a 4 o'clock position, and another position is 6 o'clock, or which is called mid inguinal type. So these are the different types of the vermiform appendix. Okay. Now what is the, already you have seen the blood supply, and why affection of this organ is very common, and before that I must mention that this is a part of the large gut. At the end of the cecum, at the end of the ileum, we are getting the beginning of the large gut, the cecum. So it is a diverticulum coming out from the cecum, so it is a part of the large gut. But there is some similarity and dissimilarity. The large gut has got 3 cardinal features, like Taenia coli, second is circulations, third is appendices epiploicy. All these 3 features are absent in appendix. It is absent in the appendix. Actually, the Taenia coli, there are 3 Taenia coli. These starts from the base of the appendix. Now about the artery, appendicular artery is an end artery. So when it gets blocked, appendix gets, it gets deprived of its blood supply, and that means the nutrition. So part will die. That means necrosis or gangrene. Okay. So appendicitis followed by gangrene is very common because of the fact appendix is supplied by an end artery, because this has got no pre-arterial anastomosis. There is no arterial anastomosis. Now, what is Mac-Barnes point? Which is also called, there is one line which is called spino-umbilical line. From anterior superior iliac spine up to the umbilicus, we can find one line, we can draw one line which is called spino-umbilical line. Lateral 1/3 and medial 2/3 of that spino-umbilical line, we get a point. That point is called Mac-Barnes point. Mac-Barnes point is the point which is situated at the lateral 1/3 and medial 2/3 of the spino-umbilical line. What is the importance? The pain is felt very much at the Mac-Barnes point. When we press the Mac-Barnes point, the pain of the appendicitis is felt very nicely. Okay. Now what is the supply? From the T10 segment. T10 segment of the spinal cord, the sympathetic. And T10 segment also supplies the umbilicus. So, at first, the pain will be felt at the umbilicus. Appendicular pain or pain of the appendicitis will be felt at the umbilicus, and ultimately it will get shifted towards the right iliac fossa. দেখো তো আর কি আছে, ওইটা তো নেই। hiatus muscularis. As per your knowledge of histology, you may remember within the muscular coat of the appendix, there are some discontinuation which are called hiatus muscularis, from where the infection from the lumen, it can enter into the, that means there are gaps in the muscular coat. So the infection from the lumen, it can enter into the peritoneal cavity. So appendicitis is very common due to the fact it is supplied by the endotary. It is in appendix, there are hiatus muscularis. Okay, and is a blind loop. Third one is a blind loop. Any fecalith gets impacted over there. So it's a blind loop. So these are three causes for which the appendicitis is very common. এটাকে দেখলেই আমরা বুঝতে পারছি, বুঝলেন, বিগিনিং অফ দ্য লার্জ গাট। আচ্ছা, এটা ধরবে কি করে? এই অ্যাপেন্ডিক্সটাকে ধরলে, ঠিক আছে? So this is the anatomical position. Okay, this is the beginning of the large gut, and here we can find the cecal sac, cecal perforation হয়ে গেছিল। Okay, cecum, ওই যে right side, the normal type, the right sac is more than the left sac, and from here you are getting the appendix. So this is the position. Okay, আচ্ছা, এবার হচ্ছে তোমার these are the circular folds. Small intestine, যেটা বললাম, circular folds. এর মাঝখানে yeah, you can find these circular folds. Okay, this is a cardinal feature of the circular folds are the cardinal feature of the small gut. Okay, now we have to fill it, both the ends. পড়েছে হাতে, মানে তাহলে ভয়ঙ্কর খারাপ কাজ হয়ে গেছে, তাই তো? Here we can find the folds are placed at a distance. Gradually they are placed at a distance. So what is the anatomical position? How we will hold it? Ileal end, jejunal end. Okay, this will become there is a fold which is called duodenojejunal flexure. Okay, from here it will start and it will end it here. What is this structure? This is the mesentery along with what is this? We can get the peritoneal covering, and here we are getting the fat, distribution of the fat. Okay, and if we try to see it against the light, we cannot find anything at all because this was a obese person. We can remember that body, okay, from where we have removed. So ultimately, whether it is jejunal length or ileal length, we cannot get the peritoneal window. Actually, here we should get the peritoneal window, okay, but because of the presence of the fat so much, okay, we cannot get the peritoneal window. In a good viscera, we will find all these structures, that is arcades, vasa recti and peritoneal window. Because of this is not a good one, okay, but we are opting for other bodies. Actually, the good bodies. Yeah, if we get it, we can show it. So now, how we can identify? These are circular folds, okay, and gradually these folds are becoming, gradually it will become less and less, okay. So this is the jejunal end and this is the ileal end, okay. This is the ileal end, okay. You can find they are placed at a distance. Here they are very much closely placed. You can double tube filling we can have. Here we are getting at a distance, okay. They are present, but they are present at a distance. So this is the ileal end. ঠিক আছে, এইটুকুনি. So we can hold it like this. এইটুকুনি, আর কিছু নেই আজকে। হাতে ধরো, ধরে ধরে দেখো নিজেরা। ডাবল, এখানে যেহেতু এইগুলো আছে তো ডাবল টিউব ফিলিং হয়। আচ্ছা, মানে দুটো দুটো করে আছে দেখো। এখানে ঠিক সিঙ্গেল টিউব ফিলিং, এর এইখানটাতে দেখো সিঙ্গেল টিউব ফিলিং হবে, সিঙ্গেল টিউব একটা, ওটা তো ডাবল। ওকে বলি দেখে দিতে। না না, ওই আছে আছে আছে।